Okay, welcome everybody. It's great to have you all for this very timely webinar today about COVID-19 and the continued role for testing in this pandemic. My name is Jan Hartmann. I'm the president of the German-American Business Council here in Boston, also the chief medical officer for Humanetics. And it's a pleasure to welcome you all for this seminar today. This is the fifth event in a series of a collaboration with the Consulate General here in Boston, as well as the German-American Business Association in California and the Consulate General of Germany in San Francisco. We're looking forward to this discussion. We're grateful for the sponsorship. And I would like to introduce Nicole Menzenbach. She is the Consul General of Germany to the New England states. Nicole, we look forward to your welcome address.
Yes, good morning. Thank you. Thank you so much. So good morning, good afternoon, and good evening from wherever you may be joining us. It's a great pleasure to welcome all of you. I'm delighted that once again, the German consulates and business organizations from the East and West Coast have brought together a group of esteemed scientists and experts from academia and industry. Today, the discussion is about COVID-19 testing as a public health tool. Unfortunately, Dr. Karl Lauterbach is not able to join us today. Last week, he was appointed to one of the most difficult and most important jobs in the new German federal government. I would like to take this opportunity to congratulate him on his new post as Federal Minister of Health. The pandemic will remain a central challenge for the foreseeable future. And with the holidays just around the corner, we continue to worry about new strains of COVID-19. It is clear that COVID testing will remain a necessity. What role will testing play for international and domestic travel? Can testing keep schools and universities safe? Today, we would like to hear from our experts about how they envision future developments and future public health policies in the face of rising COVID-19 infections. We want to hear if and how we can more effectively leverage COVID-19 testing as a public health tool. I would like to thank our esteemed guests and panelists for joining us. I'm excited to listen to your discussion. And once again, I would like to thank our partners at the GABC and GABA and my colleagues in San Francisco for the organization of the final webinar of this year's COVID-19 series event. It has been a great pleasure to work with all of you, and I'm very much looking forward to joining forces again in the future. So now, without any further ado, back to you, Jan. Thank you.
Thank you, Nicole, and thank you and welcome to our guests and panelists today. I'm really grateful for them joining us today, and I think we have a great group assembled that will answer key questions around testing that we all may have as we're heading into the holiday season and as we are, dealing with the pandemic at this stage. So first, I want to introduce Michael Mina. He is the Chief Science Officer for eMed. Previously, he's been a professor at the Harvard School of Public Health by background and training, an epidemiologist, public health expert, and a physician by training as well. You may have seen him here and there. He's been very vocal about the role that testing can play and the benefit that rapid antigen testing can have in controlling spread and in controlling the pandemic. So great to have you today, Michael.
Well, thanks so much. Very happy to be here.
Secondly, I want to introduce Melanie. She is a professor at UCSF and director of the Gladstone Institute for Virology. She's spent her career working on viruses, particularly HIV and HCV, but I think with this pandemic, I think everyone started focusing on the coronavirus at hand as well. And so I'm glad that you're joining us with your expertise in virology. And and also your experience over the last 2 years, I believe, in trying to identify opportunities for innovative ways to test for this virus. So we're looking forward to hearing about that in a bit too. Welcome, Melanie.
Thank you very much. Delighted to be here.
And last not least, Stefanie Friedhoff is joining us. She's a professor of the practice at the Brown School of Public Health. Her work is really sort of at the interface of public health, crisis communication and management, and health equity. So we're really grateful for having you with us and for your perspectives, and look forward to the discussion. Welcome, Stefanie.
Thanks for having me.
Thank you. So, I think I might open with a question, Michael, for you. I know that before the Thanksgiving holidays, which are obviously very important here in the US, you gave advice for how to keep the family safe and still have a enjoyable celebration. Now that we're heading into the Christmas celebrations that many of us are celebrating, what has changed, or what has stayed the same? What are your recommendations for how to have a joyful and safe Christmas in this pandemic?
Well, it's a great question. As you were asking it, I had to ask myself, is he talking about Thanksgiving of 2020 or Thanksgiving of 2021? And frankly, the answer is mostly the same. Of course, the big change is vaccines over the year, and the first things first, get a vaccine. That's the best way that an individual can help keep themselves from getting very sick. There's no doubt about that. But that aside, we now have variants that are doing a pretty darn good job at getting through previously acquired immunity. We have always had variants, and just the virus itself was always going to be able to continue transmitting amongst vaccinated. So it's very important to have other strategies. I think there's a very simple one, which of course I've been extremely vocal about for almost 2 years now, and that's test yourself as soon as possible before the event of interest that you're doing. So if you're going to celebrate a holiday with your family, or if you're about to get onto a flight, whatever the case may be, when you're about to be in a place where you might be able to expose other individuals, a very useful strategy is to have a rapid test that you can use literally 10 minutes before you gather. If you do that, the chances, it massively cuts down on any of the chances that you might be bringing a virus into a gathering of your friends or family. And if everyone does that, then it greatly, greatly reduces the risk associated with gathering during a period of time when we have things like Omicron spreading very quickly. So that's one of the basic components. I do think that we've heard a lot of discussion around masks, and I'm not going to say don't wear a mask. Wearing a mask is is an important thing, especially when you're out in public. But I do think it's somewhat unrealistic to ask people to wear a mask when they're eating dinner with their family. We've unfortunately heard that suggested by policy leaders. And I think we have to think of other strategies. And I think a better strategy is wear a mask in transit, wear a mask as much as you can, but within reason. We can't, you're not going to be wearing a mask and taking it on and off while eating food. And so leaving the virus out of the gathering in the first place is the best approach. And that's where a test right before you enter by everyone who is entering can really be a great benefit.
Thanks, Michael. And Michael alluded to one type of testing. Melanie, maybe you can walk us through a little bit, sort of like what are the different types of testing? We're hearing about PCR tests, antigen tests. Can you walk us through the different options and what these tests are actually best at helping us find out?
Yes, absolutely. I think, as I said, everybody is a virologist now, so everybody is very fluent in the language of PCR and antigen tests, which is fantastic. But we can just briefly recap. I think there's two types of tests, the so-called tests that directly detect the virus and really tell us whether we are infectious or carrying virus currently. And then there's, of course, the immune test or the antibody test that tells us what our immune status is and what we had before currently. And we're really focusing today on the tests that tell us whether we are infectious. And we should really remember that we need this frequent testing because of one very specific characteristic of this virus, and that is that it is infectious and it spreads before it causes symptoms. If it would be not the case, we could rely on temperature checks and other things and really keep symptomatic people at home. But this is the tricky thing, is that we might be running around spreading infectious virus at a time when we feel totally fine. And I think that is the big incentive to test frequently in order to check the status. Now, the test that we can use, I'm sure you all know, is a molecular test where we go after the genome, the RNA of the virus. That is a usually very precise test. It includes amplification, so we make sure that we get a lot of copies, so we make sure we can detect it. It can sometimes be over detecting because it also detects, even beyond infectivity in some patients. And then there is the antigen test that we have in this year, I think all experienced and used much more. Those are also detecting the virus directly, but they're much more rapid. We can do them at home. They're relatively simple, but they have a different sensitivity. They are slightly less accurate because they don't amplify, so they cannot go as deep into the individual copies of the virus. But if we just at the end, just step back and think how an infection proceeds in a person, there's a few copies of the virus coming into the cells that line our nose and potentially our mouth. And that's where the virus starts to spread. So we have very little virus at the beginning, but then it ramps up very fast and comes to sort of a type of a plateau where the equilibrium is between cells that are being newly infected and so those that are dying. And then the immune system kicks in, and then we have sort of the off ramp, and it controls the viral titers. And so the different tests that we have can really go after different stages of this infection. And while all of them pretty much pick up this plateau phase, the on ramp, which is the little bit the dangerous one, is the one where we have to pay attention and potentially test multiple times in order to make sure that we get this dynamic correctly. So that's
thanks, Melanie. I think just thinking about sort of the purpose of the test, it sounds like the antigen test really helps you understand whether or not you are infectious at the time, right? So I think that's the piece of information that we should give people at hand to make a responsible decision whether to join a gathering or to get on the train, etc. Whereas the PCR may be more sensitive and specific to some degree, at least sensitive more. But it may not come back at the time that we need it, right? Because for some folks, particularly in the US, we don't get the results of the PCR test sometimes until like the next day or maybe even later, which may be too late. You're already on that flight. So I think we also need to think about, really what practically we want to do with the test. Stefanie, I would want to ask you a bit about your German US experience. I know you've been out there with a tweet that went viral about your experience when you visited over in Germany and how that was different. And I know we talked about a bit sort of this concept of, having demand for a test in the first place, like making sure that people understand why they need it, that they need it, and that they want it, having a test available and like really accessible for people. And then also, having people being able to, responsibly respond or react to the findings of that test. So talk a little bit about what you've seen in terms of like making testing successful in Europe or in Germany specifically, as compared to the US.
Yeah, thank you, Jen. After these two, I think, really terrific framings, I'm sure many people on this call who have been to Europe this summer had a similar experience, that after in the US, we've been talking for so long about needing much better testing. You come to Germany and you find that testing is ubiquitous and available everywhere. One thing that I really learned from Michael is that we have focused on diagnostic testing in the United States for far too long and are only now sort of slowly making headway into what he has called public health testing or testing for public health. And it was striking for me to see when I came to Germany that testing for public health was everywhere, right? You get off the airplane, oh, there's a little testing station. You know, sometimes it's free, sometimes it costs maybe 5 or 10 euros. The tests are available in department stores everywhere. I brought my tests, right? I brought an extra suitcase. I have 100 and more tests. They cost 95 cents for 2 tests a piece. What that does is it really helps us overcome a number of barriers that have been an obstacle to widespread testing in the United States. One is, it is still hard to find testing. We are again seeing all these images on social media of people standing in line just because they want to do the right thing before the holidays and get tested. That's just unacceptable at this point. As Michael was saying, and you know, both Michael and Melanie have laid out why it is so important to do this, and that it is like the most important protective feature that we keep forgetting about and not setting up the right mechanisms for. So when you're able to do that, you know, you don't have the obstacle of finding a testing site or booking an appointment. It makes it much easier to quickly go in and get tested. The other thing that was so striking to me was I have a little bit of envy with all my German family because they had 2 summers that we did not have in the United States, and they had those 2 summers because of how they use the mitigation strategies that we have in a pandemic. We all know, and you know, the viral Twitter thread also got some pushback around, well, it doesn't look so good right now in Germany, right? Obviously, testing doesn't fix everything, right? And just like a pregnancy test, it is not a treatment. It is an indicator of who is infectious and how can we use that. So the other thing you would have the little Luca app, or depending on where you were in Germany, right? You have a little app on your phone, you check in when you go into a store or a restaurant, and to just tell the app that you are there, you check out when you get out, and this is a contact tracing mechanism for you to know if you have been exposed or not. No names are exchanged, right? Privacy issues have been worked out, but it is the combination of these different measures that made everybody be, you know, able to go about their regular lives. And that's what was so striking to me. We took the kids to the pool. You know, we had our little CDC cards, which, you know, were glanced at. Everybody else in Germany obviously had their vaccination status on their phones. But if your kids weren't eligible yet, or if, like us, we had just come from the United States, we wanted to make sure we were safe to others going into the pool. We just got tested, you know, free tests in front of the pool, you go swimming, all is great.
Thanks, Stefanie. And Michael, you've seen it a little bit from the outside, but I'm sure you've consulted with not just US sort of like government officials, but also like outside the US. What have you seen Europe or Germany or the UK do differently, potentially, you know, let's say differently, right? And what could the US do differently, or, you know, still change to more effectively drive the demand and you know, increase the accessibility for testing?
Yeah, I have worked with a lot of different countries in talking to them about how to implement public health testing strategies, including different times Germany and the UK and Austria and them. And what I've seen has been the major difference compared to the US is, despite setbacks in nearly every country, the US has been by far the least able to be dynamic, to change the way we do things in an unprecedented time. We also, when it comes to testing specifically, what the UK did as an example is set up, immediately recognized that the testing that was going to be required for this pandemic was not going to be one that was going to be achieved in the medical laboratories. And so very quickly they set up an entirely distinct group that was charged with evaluating rapid tests and just testing in general that was going to be used as a public health strategy. And so where we in the United States kept the entirety of our regulatory pathways within one small center at the FDA, who only has a mandate to evaluate medical diagnostic tests, the UK, for example, created a very clear 3-phased approach where they funneled tests through an initial screening, and they said, okay, these are the minimum requirements that need to be met for a test whose primary objective is to limit transmission and then set up very efficient strategies to more deeply evaluate the test based on metrics that were actually appropriate to the use case. And to this day, and by that I mean they set a few different metrics. They said a test needs to be able to identify not a single viral particle, but a viral particle that's relevant. And so 100,000 or 1 million viral particles per mil. And so they set bars that were not at the most sensitive of all PCR tests, but they said, what is a good bar for identifying a test that is going to be specific to tell somebody, yes, you should isolate right now. And they did that a lot with laboratory techniques. Instead of having manufacturers go out and run sort of very long, arduous clinical studies, they did a lot of the upfront work to identify and select the right tests based on metrics that are relevant to public health, including how fast the test is and things along those lines. What the US and a number of countries took very similar approaches. The US to this day has still failed to do that legally. There is no such thing as a rapid test for public health in the United States. Every test is considered a diagnostic test, to the point where we now have the President of the United States and the FDA themselves saying, yes, this is your medical claim, but we're telling the American public to just use the tests off-label, because they haven't been able to adjust to recognize how do they evaluate and give the right claim. And that's because we don't have a legal system or structure in this country that even has the language or the law around what would a different type of claim be that doesn't fall under medical diagnostic. And this is, one of the most egregious aspects of this is we just have the president saying that health insurers should pay for these public health tools. That is representative of everything that's been wrong. That if I was a health insurance company, I would say, why would I pay for somebody to use a test when the benefit of them using that test is not for that individual, but it's for the individuals around them? And a very clear way that I like to think of how we define what we do with our tests, there are times when a test is called a medical test, for sure, including rapid tests. But when the primary beneficiary of the test is not the user of the test, but those around them, it is by definition a public health test. The consequences of finding yourself positive are self-isolation. That is, self-isolation is antithetical to medicine. It's not a medical outcome. That's not going to help me as a person get cured of my disease if I self-isolate. It's a public health strategy that's actually damaging to me, but beneficial to the people around me. We don't have this thought process in this country, and it's probably linked to the fact that we also are very individualistic in this country. We don't have a great sense of universal healthcare and taking care of our neighbors very much.
Yeah, so I mean, it sounds like there's a lack of sort of a pathway to deal with a test that is like not the medical diagnostic test that we're used to, that tells the individual whether or not they have a disease, but really is a tool for the public health that should be broadly available. I think the other thing I observed was that Germany early on, I think, made commitments to buying certain numbers of tests off of the manufacturer, so there was more incentive for competition to come in, more companies providing those tests. So I think that also addressed some of the accessibility or the pricing at least of these tests, because to this date, I think here in the US, you pay roughly $10 for each of those tests. And I don't think that's broadly available for the broad population. With that comes a question though, Melanie, that I would want to ask you. And I know Christian Drosten and others sort of retweeted some of these studies comparing, I think, 180 different tests that are available in Europe at this point. How do I know if which test to pick? Like, how do I know which test is a good one? And how have the antigen tests sort of been dealing with Omicron and people now being vaccinated, maybe not having those high viral load levels? Like from a virology perspective, what should we think about these different tests and how to find the right one?
I think that's a very good question. I think just up front, I think we don't know yet with Omicron as much, but with Delta, what we have learned was that the viral loads are still high in the nose, so there's no problem about detecting it even in vaccinated people. The problem is that the window of opportunity of detecting it potentially for the antigen test is shorter. But we don't care actually about the off-ramp, of this detection window, because we know that the virus is not infectious at that time. We still pick it up with very sensitive methods, but it's actually not any more infectious. And that's what Michael was alluding to. I think the big question is, do we want to detect the last viral copy that we have in one patient, and is that relevant for public health or for the health of that patient, or is it really that we want to get an idea of whether one person is infectious and likely to spread? And for that, you need a certain level of virus in your nose. And I would say that so far with the vaccines and with the variants, we know that is still there. However, in a shorter window of infectivity, basically. The FDA and many have looked into the, how reliable are these methods, especially when new variants are coming up and mutations in the virus are occurring. So the PCR test, especially here with the Omicron, gave a good example, because one of the primers that is used for the PCR test had a dropout. It means it did not pick up the Omicron variant because the mutation was in the range where the primer or where the test is detecting, the PCR test is detecting. And that is actually a diagnostic that's currently been used, because it's not only one of those pairs of primers or diagnostics that are used in the PCR assays, it's actually multiples. And so that can be used now as an advantage, because instead of sequencing and waiting multiple days until this is back, we can actually say this is likely an Omicron variant or not. So that's one side. The other side are the antigen tests. So the antigen tests, we have a wide variety. Here in the US, they get tested and they get approval if they have certain quality, then they pass certain quality control measures. In general, those are using a different principle. They're not going after the genome, they're going after the shell of the virus, and they're using antibodies to detect this. And most of them are not detecting the spike protein, which is the one that is highly variable, but other parts of the particle. So they are predicted to be pretty solid and holding against mutations of the virus. But they're also currently systematically tested against those. And so this is the different aspects. So in general, I would say any test is better than no test. The antigen tests are very convenient, but they lack sometimes the last level of accuracy and sensitivity. And I think this is the area, but contrary to the PCR test, where we wait longer and have probably harder access, I think they provide a tool where we can ourselves decide we will test before Thanksgiving, before Christmas. And especially if we test sequentially, maybe twice in a row, in order to make sure that we don't miss this on-ramp, I think there is a very good reliability on these tests that they give us the correct answer. One thing that is also important and should not be left out is that it has to be done correctly. So the key is really that the sample is taken properly, that we spend the time and not just sort of cut corners here because we don't have the time, do the required amounts of turns in the nose that are indicated, and really take the time to make it work, because then if this is done properly, I think we have a very good chance that the test is correct.
Thank you, Melanie. I think what you alluded to was sort of the slight sort of like downside of the antigen tests of being maybe less sensitive, but I think the way that they're supposed to be used, if I understand Michael right, is like, it's a rapid sort of frequency sort of testing, right? Where like, some dip in the sensitivity actually may not be as critical, because you get the next test pretty quickly, and you could catch up on that. At the same time, if you have a response or you have a certain result, you can react to it immediately, which I think is a tremendous difficulty with the PCR test. So it sounds like ideally we would want to have a test that you can do frequently, that's accessible, that's rapidly doable, and if you can further increase the sensitivity, great, right? Like I don't think anyone is against that, but if that comes sort of at the expense of access or frequency and testing, it might sort of defeat the purpose that it's going after. Michael, is that sort of like a fair summary? Or?
Yeah, absolutely. There's so much, because we continue to think about testing and have always thought about testing in the form of medical diagnostics, we have to come up with a different question, which is the effective sensitivity, or the actual sort of effectiveness is the way that I think we should be talking about testing programs, not the tests themselves. And this was something we published in the New England Journal last year, suggesting that we need to measure the impact of a test and its effectiveness, not the specific accuracy of one individual test for a given positive specimen or negative specimen. And so, for example, if you have a 2% false positive rate, then that's too high for a public health test. That might be okay, actually, for a diagnostic test. But it's not always about lowering the bar. Sometimes it's raising the bar. You have to have a fast test if it's going to be effective. And I would argue that more or less 99% of the tests that were performed throughout all of 2020 in the United States had an effective sensitivity of about 0%. Because they were given back after 3 or 4 days throughout much of last year, or 7 days. And the moment you have that, then it's no longer an effective test. Even if it catches 100% of people and you were to do a test on everyone every single day, if all of those tests take 4 days to return, then even if you're testing every single person every single day, which obviously we don't do, then even in that scenario of frequent testing, the long duration to get the result back would have made that process largely ineffective, despite massive energy put into it. And that's unfortunately what has happened. So frequent rapid testing, they are specific to the infectious period, and that means that they're going to have a great ability to identify the most infectious people, who also, of course, happen to be the most important people to identify.
Right. Stefanie, I'd like to ask you, in terms of communicating in this pandemic, we obviously have done many things right and probably as many things wrong. Specific to testing, you see a lot of sort of like, social media posts about that one event where somebody got tested and it didn't pick it up, or, was contradicting the antigen test with the PCR test. You've been in like public health for years. Can you share with the group a little bit this sort of paradoxon of public health, that like if you're successful, you won't see it, but if it fails, everybody sees it. And like, talk a bit about that inherent bias, because I think a lot of people see this and see those questions that are raised. And if you look at the individual cases, yeah, it does make you wonder if the test is actually working. But I think we need to pull ourselves back up to the 30,000 foot level and see this as a public health strategy. And like maybe you can help us sort of like think through this a little bit, how we can understand it ourselves and how we can help in our decision making and advocating to make this clearer to people.
Thank you, Jan, for the question. There's a lot there. I think testing is a good example for all the pandemic lessons learned, right? There's a lively discussion about pricing ongoing. We've walked through, right, how we've just not conceptualized, right, how we could be using testing. Even once you have made that step and just say you have ubiquitous testing available for everybody, the question is still, why would anybody get a test? And how do they know it's the right time to get a test, right? It's unlikely that the whole population will go get a test every day, which obviously nobody ever said they should, right? But how do we think about providing people with the right information to know at which point you should be seeking a test? From a communications perspective, what has happened with testing is, again, a parallel to what has happened with vaccinations and communications around the pandemic in general, which is that the role of experts has risen, especially on social media. And we've watched some fantastic outcomes of that, meaning, everybody's now a virologist, as Melanie says, because, hey, we can all follow the virologist on Twitter and they're having this awesome conversation and we're all learning a lot. And that is an amazing outcome, right? The way that science has been sped up because of the possibilities of exchange we now have through social media. The downside of that is that a lot of words and discussions are shared in the general public in a way that doesn't provide people with an understanding of how to think about those things, right? And if you put that together with the already long known dynamics of how news media work, which is the outrageous example of I tested and it gave me a positive and I couldn't see grandma, and then it turned out it wasn't actually positive, is so much more a story that will get people to click on it and read it than the story of 99.9% of tests are doing exactly what they're being asked to do, right? And again, we see that with the mandates, for example, right now, we see the same pattern that we all hear about the whatever 10,000 healthcare workers that chose not to get vaccinated, as opposed to the 10 million that did, right? The rates are below 1% in terms of people that are not adhering to the mandates. So for testing communications, we have sort of missed the boat in explaining this early on. Nobody is in charge of communications, and this goes back to some of the comments that have been made in the chat around the lack of infrastructure affects everything. So if we take a lack of public health infrastructure, what that means is we worked early on, like in March and April 2020, with the Massachusetts state government on trying to help them communicate around testing. There were 1.5 people in charge of all pandemic communications. And if you look across the country, that is off. So then you hire consultants, or you hire a communications company, you hire people that don't have a public health background, right? Wherever states such as Vermont have been able to use really good communications, they have been able to bring up testing rates and to get people excited and interested in testing and using those mitigation measures. The other thing I wanted to add there, also per your earlier question, is communication is really important, and for people to get clarity. At the same time, communications cannot fix the underlying problems, especially the lack of a social safety net. And this is where the comparison to Germany is also really interesting. As you were mentioning earlier, if I test positive, then what do I do? Part of the demand has not, even if I understand everything about testing and why it would be helpful, and even if I say, oh, sure, I want to help my neighbors and I want to do something good for my country. If I test positive and it means I get sick and I won't get my wages for a couple of days, right? Then I am much less likely to do that. And one of the issues that communications materials always struggle with, especially for underserved communities where we have really high rates of infections, hospitalizations, and deaths, communities that have been disproportionately affected, also have the least incentive to get tested. Who takes care of my kids if I get tested, or if I test positive, right? All those questions are in the room, and you can do any flyer or like all the Q&As that you want, right? These are not questions you can answer with communications. They really need to be fixed with the right structures and supporting actions, again, by the public health system.
Yeah, it's interesting you bring it up, because Michael earlier said something around us being individualistic in the US, right? And I think one of the things that it feels like is sort of a bridge that we might need to build is that actually almost the most selfish thing to do is to have everyone else tested, right? I mean, the test is not for ourselves, it's really like to protect others, and in turn, having others tested as much as possible will protect us as well. I'd be curious, Michael, in terms of the resources required, right? There was this famous White House press briefing where the question was asked, or ironically asked, if we should send tests to everyone, and quite frankly, some people, I'm sure you would argue, yeah, that's exactly what we should do. Let's assume that for whatever reason we cannot prioritize or don't want to prioritize to do that, and we only have a subset of those resources available. where would we most effectively deploy the test? Would we do it in certain high-risk populations, professions? Would we do it in regions with high, like, transmission rates? How should we think about this? Like, we're a rich country, but I think the resources allocated to that are not unlimited. So how can we use those limited resources the most effectively?
I mean, that's a very, if we're thinking in a global sense, or even just in terms of all of the different approaches we could potentially take, then there's a lot of different answers to that question. But on the side of testing, focusing on testing, the entirety of the United States could have had wide access to rapid tests for years, for less than 1% of what this virus has actually cost the United States. So I've heard a lot of people say, oh, that would be very expensive, that would be too much, but we make more bags of Doritos in a day than we make rapid tests, and soda bottles and such. And so these tools can be made very, very efficiently and very effectively. So it doesn't need to be a resource drain. And I would argue we have to think about them in the appropriate way. For example, if we could actually limit spread, let's just go to an extreme example and say we had actually created strategy that worked, because we always forget about the aspect of all of this, that it requires strategy to really make these tests work at a population level. But let's say we did that and it actually limited spread. Right now, it costs the US throughout this pandemic way more than $1 billion. Every single day of this pandemic has cost billions of dollars for the United States. So if on aggregate, we were able to cut down on the number of days that we were closed down as a country, that would have more than paid for it and created the resources to actually bring all of these programs to life. We unfortunately don't have a way to quantify and put that into a budget. What are the projections? I mean, we talk a lot about projected money saved in the business world and things, but it's not, we don't have a good structure, I think, to recognize what the value is of public health prevention. And we only look at it as a cost. It's kind of like pathology labs, actually. Pathology labs are often seen in a hospital setting as a cost center, even though they're actually making revenue and bringing dollars back into that hospital. It's the same thing for public health here. So I think that resource allocation for making tests itself just shouldn't be an issue. Then the question is, how do we actually get them utilized the most? We can create strategy. I think one of the most important and least expensive tools that we've never weaponized against this virus to this day is owning the narrative in a way. We allowed the narrative around this pandemic to be entirely driven by headlines, entirely. And the CDC should have hired the best marketing agencies in the world so that they could actually get people to understand actual information. That's also assuming that the CDC was giving the right information, but it's a different question. And I think that we haven't used the media during a pandemic in the right way. We could have, somehow big companies can figure out how to tell somebody who's never heard of a bag of chips that they want to eat that bag of chips. We can get the information to people that would help people work collectively to actually limit spread in a much more powerful way. And that is, a process of actually trying to create good information that people can actually consume and interpret and understand across all aspects. Whereas the CDC website is a massive failure if its goal is to drive average people to understand anything. I think that that's actually that kind of underpins everything. If we want to do real public health, we have to improve the way we describe and message and convey information, and not let New York Times headlines drive the way that people actually think about this virus, or Fox News headlines, whatever headline you choose. And I do think that if we don't get that piece in place, it's very, very hard to get collective action. And the only way you battle a pandemic where you need collective action is to have people understand that they're all working towards a goal and get them to understand what that goal is. Just like the military, we would never send troops out to fight a war and not have a strategy that they all understand. You have to understand strategy, and we just haven't ever developed a strategy really to this day at a national or a global level.
In line with that, Stefanie, have we done a good job in showcasing the success examples? I'm just thinking about sort of, universities, the NFL, NBA, like, well sort of funded institutions that have a keen interest of keeping themselves running and open and all that seem to have done pretty well, and all of them seem to have deployed some level of testing. Has that been communicated sort of well enough, like as a success example? I mean, I would extend the question even to private businesses, because I know we have a lot of entrepreneurs and sort of folks running businesses here on this webinar. Like, what value does the testing bring, and like why aren't we communicating this more clearly?
Great question. I think the ugly truth is that, especially for those of us, I'm making an assumption about the audience, right? But that have access to resources. A lot of our children have been able to go to school because they go to schools in which we've had testing programs, and the schools have been able to stay open. Same is true for universities that have implemented these programs before vaccinations were widely available. What Michael said earlier is 100% spot on, that we have really good marketing and communications tools that we could be using, and nobody feels like they're in charge of it. I have been trying to find numbers. I can't find numbers for testing, but I can tell you that we have spent over $50 billion on the vaccination distribution rollout, and we've spent between $2 and $3 billion of that on communications. We are all in supply and no demand. So the story has been told somewhat for the NBA and players like that, but that doesn't actually translate to individuals and their realities. I think that's the key point here. We need to make it accessible for each individual. And what you really need to understand about communications at this moment is there's no national campaign that will do anything. This needs to be localized and culturally competent. Because right now, everybody on this call is thinking about what their plans are. Are there going to be 10 or 20 people for the holidays around the table? How many of them are going to be vaccinated? What are the tests that we're going to be using? Where are they coming from? It's like there's a whole subset of decision making and questions that are unique to each community, to each family, and so forth. So what we see in using effective communications is that it needs to be at the local and at the ground level. We have a complete mismatch. So the communications that we have seen are, again, flyers and websites. Again, the CDC page is a disaster because you cannot understand it if you don't have a lot of prior information. We're just not out on the media that people actually consume, and we're not out there in a way that the information is accessible. That's one of the big failures, again, in the pandemic in general. In terms of making it more digestible, or for our own families, I think it's important to focus on the tests. I don't know if people actually have trouble getting everybody to take the test, right? I just shared a resource in the chat for people to look at that can really help and provides some very easy to go information.
Right. I think that's really it's helpful to understand, but I think it's a big challenge, and I think having success stories or positive examples that can cut through the noise and sort of motivate people to create that demand for testing, I think is important. Melanie, I want to talk briefly. I know we got a lot of folks from the West Coast, tech savvy people, and we're all sort of keen on these German American success stories of BioNTech and Pfizer and so on. Tell us a bit about what your lab has been doing to innovate how testing is done, how you can use your cell phone to actually get yourself COVID tested.
Thank you. Yes, I think it addresses maybe some of the questions in the chat, which are about, do we need more accurate tests that are convenient and cheap, like the antigen tests. And I think that's exactly what we had set out to do already now 4 years ago, together with Jennifer Doudna and Dan Fletcher here in the Bay Area, where we really tried to combine Jennifer's Nobel Prize winning CRISPR technology with Dan's pioneering work in using mobile phones as diagnostics, and not just as a tool where you Bluetooth to another apparatus, but really using the camera as basically a reader of the diagnostics. And we started this for HIV, pivoted last year to SARS-CoV-2, and got some good results relatively fast, and had to go through the long and tedious way of developing this from scratch, basically. But the idea is really very much in line with what Michael very early in the pandemic has said, that we need to give access to everybody to testing in order to, as a public health tool, in order to keep our numbers down, in order to make sure that people stay home when they are infectious. And what is more widely spread than a mobile phone to do this? Now, the principle is really of these, you have probably heard about CRISPR as a testing tool. There are CRISPR tests out there currently. They are very similar to a PCR test. They use amplification and then use the CRISPR enzyme to detect whatever is being amplified. What we have been set out to do is really using CRISPR like an antigen test. Instead of the antibody, we're using a CRISPR enzyme that can bind to specific RNAs here, the SARS-CoV-2 RNA, and really within minutes can light up a reporter that we can then in real time pick up with a camera of the phone. This was described already earlier by Jennifer's lab, but the question was always sensitivity, and we have talked a lot about sensitivity. So in this last 2 years, we have been pushing down the sensitivity to a level where it compares now with PCR. We have also done new level of droplet detection, where we, instead of using an Eppendorf tube or a little tube to do the reaction in a larger volume, we condense it into a tiny little droplet, and that increases the sensitivity dramatically. So there's a lot of innovation that goes around there, where we hope that one day we will all be able to basically test every day with our own cell phone at home with the precision of a PCR test, because as you all note in the chat, is that antigen tests are less accurate. And I want to re-emphasize, antigen tests are no diagnostic tests. If you really want to know whether you're COVID positive as because you have symptoms or you have been exposed, I think I would say go and get a PCR test, or get some of these newer technologies now that put a PCR test or a similar test like a PCR test into a little machine that you can operate from home. Again, these are complicated machines. They need to do a lot of cycling in order to get the numbers up. That makes it more expensive and also longer. But I think the idea is really using new molecular testing like the CRISPR testing to do direct detection of the RNA, similar to an antigen test. And I think for me, this is really the future of RNA testing in the future, because it avoids a lot of the steps that include error, like we need to translate or transform the RNA into DNA, then we can amplify it, then we have to put it back into RNA in order for the CRISPR to work. So lots of different steps, I think, that we can easily avoid if we're really pushing the envelope here, and that's what we're trying.
Thanks, Melanie. We keep our fingers crossed for you and your collaborators that you're going to be even more successful in the last 2 years. So we see this all, like, when the next variant or the next virus hits. And maybe in closing, Michael, to sort of close the circle, come back to the initial question about the Christmas holiday, but also again, like for our business colleagues here that are making decisions on behalf of employees. Just talk to us a bit about the Omicron, like the situation that we're facing now, because I think there might be some concerns or misunderstandings out there. Just help us sort of like think about how to create a safe environment in this season. Like, it's not just the Christmas holidays; it's the entire winter that we need to manage as a society.
I think along with the testing has probably been some of the least well messaged and most confusing aspects of this. And so I get a lot of questions which are just very pointed. How accurate are they? Are they good? And I think I've already addressed it a bit, but in general, the tests are thus far very, very accurate. If your question is simply, am I a great risk to people around me? They work well for that. One piece that's been very, very confusing, and that we've seen even Cochrane reviews and other like reputable sources, including, first and foremost our FDA and CDC, continue to confuse the metrics by which we evaluate tests. So I want to be very clear that there has been a lot of information out there saying a rapid test, for example, is 50% accurate or 50% sensitive. We have to understand that that is when compared against people who are not infectious. So you don't want to ask somebody who's not infectious to isolate. That's kind of poor public health planning. So when we take a PCR test that's positive after somebody's been infectious, and they are no longer positive on the antigen test at that same time, that shouldn't be considered a knock against the antigen test, but it falls into, it's why people are so confused by saying, oh, these are 50% sensitive. It's actually not true. When we actually look at how sensitive are they for what we actually care about, do I need to isolate? Am I infected? Rapid antigen tests have proved to be very, very effective for that question. We're starting to see technologies like Melanie is creating, and I feel privileged that she's shared some of the early data with me in the past. And I mean, we're going to see a new revolution in technologies that are going to make us no longer have to have that compromise, that we can actually have fast tests that are even more sensitive. We're not quite there yet for use at a population level. So unfortunately, antigen tests are kind of where we're at the moment for getting widespread use for things like Christmas this year. A lot of people are concerned about Omicron, and we're also hearing interesting stories about, well, I'm negative on the antigen test, but I'm symptomatic. There's a really interesting story here about why the relationship between symptoms and infectiousness has fundamentally changed, not because of Omicron, but because people are now vaccinated and previously infected. And the whole reason we get vaccines is so that our body elicits an immune response very fast after somebody gets exposed, even maybe before they're infectious. So by definition, you actually start to create an immune response very quickly if you've already been infected or vaccinated. And that means that you become symptomatic, because symptoms are oftentimes the expression of your immune response protecting you. So we've now seen where before symptoms would start after viral loads started really transmitting, we're now seeing that if you become symptomatic, it's often actually before you transmit. So we have to always be dynamic about keeping up to date. What does a symptom mean for transmissibility? And unfortunately, our regulation isn't set up to be that dynamic to actually say, oh, we've changed the immunological landscape of the country or the world. So that's one piece. And then a lot of people are questioning, do rapid tests still work for Omicron? So the vast majority will. Omicron thus far has 4 mutations in its nucleocapsid protein. And the nucleocapsid protein is what the rapid antigen tests detect. 2 of those mutations have shown not to be important for rapid antigen tests. 2 of them are in a part that they don't recognize. So it shouldn't be an issue, but we do have to continue monitoring all of these new variants to make sure on a test by test basis, manufacturer by manufacturer really has to continue monitoring. So far, we know that like Abbott's put out a press release saying their test works. And I think we're going to keep seeing companies either have to pull their tests off the market or be able to show that they still work for Omicron. But Omicron hasn't vastly changed its nucleocapsid part of the virus, which is where these tests bind. So it's not as big a deal as many people think, actually.
Thanks, Michael. And I think what I take from that last sort of like comment is the point that this is all very fluid and continues to be fluid. And I think that has been one of the challenges too, that the best available scientific information at a given time may have been different, like, from 6 months ago, which doesn't mean that it's contradicting each other. It's just a different set of information on which to act. And I think it's difficult for the lay population to follow and understand. And I think can be easily exploited if you want to for other purposes. So thank you for bringing some sort of like, light of like understanding about these tests to this webinar. thanks so much for your time and for all your efforts around testing and fighting this pandemic in various roles that you have. On behalf of the German American Business Council and all our cooperating partners and collaborators and the consulates generals in Boston and San Francisco, thank you so much. And we will continue to have that dialogue, and we will continue to respond to questions in our own social media forums. So feel free to reach out to our panelists, to myself, and we will be back with more in due course. Thank you so much, and thanks to everyone for joining today.
Thank you. Bye-bye.
Thanks for the great discussion.